Ladies and gentlemen, my name is Jeff Shammy. Some of you know me. I'm the president of the Cedars Cancer Foundation. A great honor today to welcome you to our Cedars CanSupport Lunch and Learn with Professor Jeremy Howick, all the way from the UK. If you allow me to take a moment, and then I'm going to introduce Dr. Justin Sanders, our Chief of the Division of Supportive and Palliative Care, who will introduce Jeremy. But I just want to take a moment to say that this is a special day for us at Cedars. Not only can we have education seminars, bring healthcare workers, volunteers, caregivers, professionals, those interested together, but to do it at the Cedars Cancer Center, where we're the patron of this wonderful center, helping cancer patients and their families every day. At Cedars, we've always believed that exceptional patient cancer care must address the whole person, not just their disease. We want to ensure that our patients receive compassionate, personalized, quality care at every step of their cancer experience. And for 21 years, I've been privileged to head the Cedars Cancer Foundation, and our mission is very simple. We raise philanthropic support for patient care, cancer research, and cancer education, and we do it for the full continuum of life. Kids with Cancer, Sarah's Floor at the Montreal Children's. Now we have the Jackie Aze's Adolescent and Young Adult Fund, helping the vulnerable patient community of those 16 to 30-year-olds that need specialized care. We're launching a geriatric oncology program, helping this vulnerable patient community with specialized care. And of course, bringing respect and dignity in supportive and palliative care when we need it. Over the past 10 years, the Cedars Cancer Foundation has invested more than $20 million. I looked at the figures, ladies and gentlemen. It's quite impactful in supportive and palliative care programs and services. This includes PSO, psychosocial oncology. I see our director, Dr. Mark Hamel, in the house. Cedars CanSupport. I think Gwen Nakos, our founder and past chair of Cedars, is in the house. And a little small anecdote, Dr. Howick was the first inaugural Tom and Gwen Nakos visiting professor in supportive and palliative care in 2023. And Jeremy, we're so happy to welcome you back, but I'll leave that for Dr. Sanders to say. And I want to also thank the vision of the late Wilfred Howick. And his sons are here, Andrew and Peter. And Wilfred was a great friend of Dr. Taba's, one of the founders of the Cedars, 61 years ago. And Wilfred Howick started the Humanitarian Fund, which our social workers and our Cedars CanSupport team every day help our cancer patients in need, those with special required resources, and Cedars and the Wilfred Howick Humanitarian Fund is there. So I wanted to shout out to that humanitarian of great stead. Last two things we have in common is I wanted to mention Professor Jeremy Howick, our keynote speaker, is the grandson of the late Wilfred Howick, as I mentioned, and as I said, the first Tom and Gwen Nakos visiting professor. Without further ado, before I ask Dr. Justin Sanders, the director of the Division of Supportive and Palliative Care, to come forward, those participating by Zoom, please keep your microphones mute. S'il vous plaît, pour tous vous participent par Zoom, je vous demanderai de garder votre microphone fermé en tout temps. You'll have an opportunity to ask questions after Professor Howick's presentation. I'll moderate a Q&A. And without further ado, Dr. Justin Sanders.
Thanks, Jeff. Thanks for everybody for being here today. Thanks to the foundation for these great opportunities to learn and to eat together at lunch. Professor Jeremy Howick is an internationally recognized researcher in empathic healthcare, evidence-based medicine, and placebo effects. His work brings together philosophy, clinical science, healthcare innovation, and policy to improve the quality and humanity of healthcare. His mission is to ensure that a dose of empathy is included in every healthcare consultation, and his work spans academic research, clinical training, international collaboration, and healthcare reform. He was the founding director of the Oxford Empathy Program, the inaugural director of the Stonygate Center for Empathic Healthcare, and founder of the Global Empathy and Healthcare Network and Global Empathy Solutions. With more than 250 publications cited over 20,000 times, his research has advanced innovative methodologies, ethics, empathy, and leadership in healthcare. His scholarship on empathy, evidence, and healing seeks to transform healthcare by bringing scientific rigor and human connection together in clinical practice. As Jeff said, this is the second time we've had the opportunity to welcome Professor Howick here, and I'm delighted to welcome him up to give a talk. So thank you very much for being here.
Thank you, bonjour. Je vais parler en anglais, mais je suis content de prendre des questions en français après. Can you all hear me?
Yeah.
Good. What's the secret to make this thing go ahead?
There we go. Want to advance the slides? Yeah. Just use the arrows.
I did.
You did. Let's press ear ones.
If there's no technology problem, there we go.
So ear.
I'm going to argue that empathy is evidence-based medicine. I don't have any conflicts of interest related to this talk. It's really great to be here because I was born at the Montreal General Hospital. I think was it the 8th floor? Is that where the kids are on? I forget. I don't remember. Obviously, I think I heard it was the 8th floor. It's also humbling because the McGill University Hospitals Trust has a long tradition of great people, including but not limited to Sir William Osler, who's widely regarded as the godfather of modern medicine. This is him circled in red at McGill University semi-centennial in 1882. I should warn you, I'm not a qualified healthcare practitioner, but according to the Oxford English Dictionary, anyone who assists in the birth of a child is a midwife. And this guy here, I'm not sure if he made noise and had to leave yet, but he's here somewhere. He'll come back in. I had to catch him at 1:49 a.m. on September 2nd, 2023, a few months after I gave the lecture. It wasn't planned to be that way. It just happened very fast. I had to do it. It's a harrowing experience. I don't recommend it unless you're fully qualified. What I have done, though, is 20 years of research on empathy. And my main innovation has been to treat empathy as if it were a drug. If you want to get a drug approved for marketing, you must do randomized controlled trials, systematic reviews, etc. And we are doing the same thing with empathy. I'm going to share a bit of the evidence with you today in language that I hope you can understand. My research has always been deeply personal. When I used to row, I developed an allergy to a cat, and my training was suffering. My sleep was suffering. I was suffering. I was becoming more anxious. It was a vicious circle. The doctor prescribed a corticosteroid nasal spray. I didn't want to take it for fear that it would lead to a drug test, a positive drug test for a banned substance. Turns out it wouldn't have, but I didn't know, and I was having trouble finding out. As a last resort, I went to visit a herbal doctor. I thought it would be rubbish, but again, it was last resort. And it was the same as any other doctor, except for instead of having 10 minutes, I had an hour to speak not just about the symptoms of the allergy, but also of the anxiety associated with high-level rowing and so on. In the end, she said, keep your head and neck warm, which is just common sense in Montreal in the winter, but I didn't have common sense all the time, and drink ginger tea. I thought it wouldn't work, but then I said to myself, it can't kill you. Billions of people drink it. It's one of my 5 vegetables a day and fruits a day. I'll try it. After 3 days, my allergy symptoms all but disappeared. That got my kind of academic mind worrying. Was it the placebo effect? If it was the placebo effect, how could we design a placebo ginger tea? It's almost impossible. Or was it the empathy that the practitioner gave to me, the long consultation, the long time discussing not just the symptoms, but the whole person, as Jeff mentioned. So empathy is evidence-based medicine. I'm going to talk to you in 3 acts. 1, the crisis, 2, the evidence, and 3, the cure. The crisis. There's a story, a true story reported in the BMJ in 1998. A 40-year-old woman died of smoking-related lung disease. She never went to the doctor for the last 2 years because she was scared they would judge her for her smoking, as they had in the past. The doctors who wrote the article in the BMJ said that they could have averted her early demise had she visited them. And they said that the reason, in her sister's words, she didn't visit the doctor was they lacked empathy for her. So lack of empathy can be dangerous. It's not just anecdotal. Report after report after report in the UK has come out on avoidable, tragic deaths, avoidable deaths. And they all name lack of empathy as one of the causes, not the only cause, one of the causes. In the most recent review, the Amos review, Baroness Amos interviewed me for the review. It came out two weeks ago. It can be further generalized. We did a systematic review of almost 70,000 patient safety incidents. 1 in 10 patient safety incidents is caused solely by poor communication, according to the authors of these reports. 1 in 4 patient safety incidents has poor communication as one cause, among others. Now, it's not just that poor empathy, lack of empathy and poor communication cause adverse events. It also causes low levels of satisfaction with the healthcare profession. We've shown this in a major study. In the UK, satisfaction with healthcare is at a near all-time low, with only about 1 in 3 people claiming they are satisfied or very satisfied with healthcare. And it's not just in the UK, it's a global problem, including here in Canada, where the satisfaction with healthcare has dropped 13% in the last 5 years. In primary care too, it's a problem in Canada as it is elsewhere. I found a Google review of a hospital in Canada. The Google satisfaction review is 3.3 out of 5. I'm not going to say which hospital it is because I still want my free lunch. But the point isn't to point fingers, it's to say that low satisfaction is a global problem in healthcare. It's not just that it's low satisfaction, it depends what social group you're in. So in the UK, the Reform voters have much lower levels of satisfaction than the Lib Dem voters, for example. The Black patients have higher satisfaction than Asian patients. It depends on what group you're in. Here, again, that's a global phenomenon. Here in Canada, it's the same thing. Indigenous people report discrimination, as do some other groups. So poor communication can cause patient safety incidents. It can contribute to poor satisfaction. I'm going to argue later that, and provide evidence that low empathy is co-related with high burnout. So low empathy means more burnout. But for now, just take that for granted temporarily and acknowledge that burnout's a major problem in healthcare. In the NHS loses almost 750,000 person days per year because of burnout-related illnesses. And again, it's a global problem, including in Canada. And all these things are connected. The poor communication, low satisfaction, and patient safety incidents. In one study, physicians with signs of burnout were twice as likely to report a medical error. Given how important good communication is and empathy is, we would expect that medical students' empathy goes up as they progress throughout their studies. In fact, most studies that measure it find that empathy goes down. Bob Behrens was the former ombudsman for the National Health Service in the UK. He said there was a deep-seated lack of empathy and that medical training had to be redesigned to encourage more empathy. This is all average, of course, and I'm sure that the people in this room are exceptional and it doesn't apply to them.
Le adulte C02 44 22 CT scan. Attention, attention. Code blue adult C02 44 22 CT scan.
So we looked at the reasons why empathy might decline as students progress through their studies, and it's the hidden curriculum. The hidden curriculum, things like poor role modeling. No matter what you teach medical students in the classroom, if they go in the ward and meet a doctor who's not empathic, they mimic that behavior. Role modeling is a stronger predictor of behavior than anything we teach them in the classroom. Also, medical school is hard, it's stressful, and so on. These things tend to drain empathy. It's the same thing if you look in clinical practice. Despite the importance of empathy and communication, the extent to which qualified healthcare professionals express empathy, according to patients, varies widely. Some do it very well, not all do it very well. I learned this when I first began giving talks like this to nurses. They said, Jeremy, we nurses, anyone a nurse in the room? Yeah, they say we're the best at empathy. We do it all day. It's those general practitioners, the family doctors you must speak to. Is anyone a general practitioner? Unlikely in the hospital. I would have talked to the general practitioners. They said, we do this all day. It's all we do, actually. It's the main thing. Our main treatment is empathy. It's those surgeons you got to speak to. Who's a surgeon? Oh, they're scared to put their hands up. No. Yeah, there's one. And the surgeon said, who cares about empathy? All we have to do is cut good. That's, of course, a joke, and it's not true. Some of the most empathic practitioners I've ever met are surgeons. The fact is that it varies widely. Not everyone's good at it. And even those who are good at it can use a top-up. To summarize Act 1, empathy is not there as often as we'd like it to be. Low empathy harms patients and harms practitioners, and medical training drains empathy. Act 2, the evidence. What's the evidence that more empathy makes a difference? The first thing to say is that I've got to define empathy. One person told me, Jeremy, there are as many definitions of empathy as there are researchers like you researching empathy. It turns out he was only half right. We did a systematic review. We found all the definitions of empathy we could find in literature. We found almost 4,000. And then we analyzed them, though, in random batches of 10 to see if they were actually that different or not. What we found was that despite the apparent differences, they all meant the same thing. Empathy involves listening, understanding, exploring, being curious. Feeling is okay, not necessarily the same feeling as someone else, but feeling all while maintaining boundaries. So the way I express this is what's called the narcissism of small differences. Academics like Justin and I, we get kudos if we publish more papers. So Justin might publish a paper, or I might publish a paper. He might find one sentence mistaken and publish a whole paper, why that sentence is wrong, and then we both get more citations and so on. So we're incentivized to exaggerate differences. I used to row for Oxford, for example. That's not me, but that's a picture of Oxford. And when you're rowing for Oxford, you hate Cambridge. Hate them. Then after you become friends. But the fact of the matter is, there are no two groups of people more similar in the world than Oxford and Cambridge rowers. I found a picture of McGill Queens. They still hate Queens when they're at McGill. Yeah. So did you get your master's at Queens? Yeah, Queens. So you must have got a lot of flack. Okay. So when you go to Queens, they hate them. I saw one T-shirt, Queens underlined sheep and so on. I won't say the word. So they hate them. The fact of the world, there are no two groups of people more similar in the world than McGill and Queen's students. They might not like to hear it, but it's a fact. So we exaggerate differences, but the empathy means what you think it means. Some other people say, Jeremy, what you're talking about empathy, we mean compassion. It might surprise you to learn that's okay if you want to call it compassion. We mean the same thing. But also, if you look at the definitions of compassion, it includes empathy in most common definitions. The way this is set up, I can't read this, but obviously the way empathy is expressed depends on the culture, the context, and the setting. Therapeutic touch might be very appropriate in some settings and offensive in others. Talking about feelings might be something some patients want and other patients might not want at all. I've got to memorize this anecdote, but it's my favorite one. We're writing a paper about how empathy is expressed differently in different cultures. One's from Japan, one's from Nigeria, one's from India. The one in Japan, for example, extended eye contact is rude there. So for them, empathy does not involve extended eye contact, and just looking down and being quiet is important. But this one is an anecdote from Scotland. My colleague Stuart Mercer, his first week after graduating, fully qualifying, was in his GP practice in Glasgow, in a rough area of Glasgow, Scotland. And a big guy walked in, 6'6", big guy, overweight, full of muscle, full of tattoos. And then the first thing the big guy said was, before we start, I got to warn you, I don't like fucking doctors. He said, oh, damn. Nothing in my training warned me about that. And then he just, by instinct, he said, oh, yeah, sometimes I don't like them. Sometimes I don't like them either. And the guy was surprised. And then as my colleague walked over to get his notes, the big guy noticed Stuart was limping and asked him why he was limping. Stuart explained, I lost a leg due to childhood cancer. They began to have a relationship, and over a series of consultations was able to help this guy who had lost his job, stopped going to the gym, had undiagnosed diabetes, hypertension, etc. So just an example where, it's coming back. The test. Just make sure people want to have a siesta. So it's an example where the way you express empathy differs depending on the culture and context. Also, you can teach empathy. Some people say it's in your DNA. You're born with it or not. We found 26 randomized trials showing clearly that in fact you can make a difference. Empathy training does change behavior. You can also measure it. There are various ways to measure it. Validated tools. We've got our own validated tool coming out. It's a simple one with 5, just a happy faces scale. You just say, ask patients to rate their doctors. It's coming out. It's just been accepted for publication in PLOS Medicine. Now the evidence. So randomized controlled trials, the same kinds of studies that show that drugs work, have shown that patient satisfaction goes up. The amount of morphine required to reduce postoperative pain goes down by 50%. And think of that. How many people after an operation become addicted to morphine? What if we could reduce that by even a small number for almost for free? Cellular immunity goes up by 14%. Adherence to treatment goes up. About between a third and a half of people don't take their treatments as prescribed. They say take it once a day, they forget. They say take it twice a day, they take it once a day. They don't take it at all. It's a real problem. A treatment cannot work if patients don't adhere. More empathy improves adherence because it increases trust. Chronic pain also goes down by 10%. In observational studies, which are only slightly less rigorous than randomized trials, empathy has been shown to reduce diabetic patient mortality by 40%, reduce practitioner burnout by 28%, and improve practitioner job satisfaction, making it almost 4 times higher. A more recent study found just, hey, when they ask patients general health, how's your general physical health and your general mental health? When they have a more empathic practitioner, their general physical health and general mental health is 5% higher. There's also a lot of studies showing that more empathy means less burnout. This is counterintuitive. Many people think if I'm too empathic, I'll get compassion fatigue. I'll get burned out. That does happen for some individuals, I'm sure. I have a hypothesis as to why. Please ask me in the question period at the end. But in general, the opposite's true. There's a very clear inverse relationship. The more empathic the practitioner is, the less likely they are to burn out. This can be best explained with a quote from Viktor Frankl, who said was tortured in World War II. He said, those who have a why to live can bear with almost any how. What does that mean? Being a doctor is a hard job no matter whether you're empathic or not. But if you're in touch with the fact that you're helping somebody and you can see it, it makes you feel less burned out. Equally tired, less burned out. Here's a real example of a very simple intervention that's been used, which is more about positive expectations, that's part of empathy. They randomized doctors to use one of the following 2 messages before they gave the child an injection. Either they said, we're going to give you a local anesthetic that will numb the area and you'll be comfortable during the procedure. Or they said, you're going to feel a big bee sting, which is the worst part of the procedure. And you laugh, but sometimes people do use those negative words, right? So that the difference was clear. They asked people to rate the pain they felt. Those who received the bee sting message rated their pain as 5 out of 10 on a 10-point scale. Those who had the comfortable message rated their pain as 3 out of 10 on a 10-point scale. That's a difference of 2 out of 10 on a 10-point scale, or 20%. This is only one small study. If it was bigger, you might expect the effect size to go down. Nonetheless, to put it into context, what do you think the difference is between over-the-counter painkillers and placebos in large trials on a 10-point scale? Any guesses? 20% the same as this? Anyone else?
Higher.
Higher, bigger effect, yep. The effect is so small you can barely measure it between placebo. Now, placebo is not the same as a negative message, but we're just putting it into context. You want to know how much it costs? Some people, the hospitals we're delivering our training to, they say, Jeremy, we'd love to do this, but it's expensive, takes more time, and so on. So, well, if the drug's expensive, the question isn't is it expensive? Is it cost effective? Your life has a value on it, according to the healthcare system. They gotta, resources are scarce. They gotta figure out how to spend them. Some things, if it costs a lot of money but has a big effect, it's okay. Otherwise, it's not. So what do? We did a major study, it's under review now, looking at the consequences. We took our empathy training, takes half a day. We gave the practitioners more time, and we modeled what would happen downstream based on the other evidence. You know, satisfaction goes up, pain goes down, depression goes down a bit, anxiety goes down, etc., compared to carrying on as usual. And then we checked whether empathy saved money or not. Do you think it did? Well, you know, I'm giving the talk, so anyone skeptical? Well, in primary care at a national level in the UK, the average savings predicted was 3.2 billion, and in secondary care in hospitals, 7.6 million. And the confidence around these was quite high for primary care and less high for secondary care. These are tentative, it's the first study of its kind, tentative, but it's showing a positive signal at the very least. How about AI? Is it good or bad for empathy? Good? Who says good? Who says good? Put up your hand. This is bad. Put up your hand. We don't know. Okay, bad. Okay, you've already retired. You don't worry if you lose your job. We have to be aware of the law of unintended consequences. When medical records were introduced to the hospital, they said it's going to save doctors time. The opposite happened. They spent more time filling out forms. You got to be careful when you hold the tail of a tiger.
Great picture.
Great picture, yeah. I stole it from another colleague of mine. Good poets borrow and great poets steal. He knows I stole it. Is technology making empathy better or worse? Worse. I think it's making it worse on average. In fact, we did a study, a review. We looked for studies that compared ChatGPT written responses with real human written responses. And then an independent observer rated which response was higher, was better at empathy. In 13 out of the 15 trials, the ChatGPT response was rated as having more empathy. It's a bit of a cheat because it's the written response, right? You don't get the gaze, you don't get the body language and so on. But these care bots and so on are getting scarily like humans, right? So I think we don't know, but certainly if we allow it to continue, the human empathy is getting drained, going down, the satisfaction burnout going down. And what we have to do is make sure that the human practitioners have a lot of empathy. That's what we're doing. So I've summarized the evidence. Empathy works. Empathy is likely to save money. AI might make things better or worse. What's the cure? Putting into practice. So I'm just thanking my team. Everything I've described up to now and will describe is a result of teamwork. I'm only one among 15. We produced an evidence-based curriculum for the Leicester Medical School. It's a curriculum that can be inserted into the medical curriculum to make sure that instead of going down, medical student empathy goes up. It's available it's a freely available handbook. The beta version is up now. Version 1's coming out in October this year. Our curriculum stream has 5 components. One, what we call walk a mile in your shoes. On average, medical students are younger, healthier, wealthier. Look at Andrew back there. He's going to put up your hand, Andrew. Look, there you go. See, he doesn't look like a typical patient, does he? So they're younger, healthier, wealthier on average than most patients they see. That presents a barrier to understanding. We don't want to make them sick and so on, but we can give them vicarious experiences and ask them to reflect on these with the creative writing or in groups. So we get them to visit the homeless GP surgery, for example. We also get real patients into the lecture theater, which is not uncommon. But what isn't uncommon is getting real patients into the lecture theater during the teaching of pathophysiology, learning about the heart, learning about the bones, the brain, get a patient story in there. This is good for a number of reasons, including humans remember stories more than facts. If they can latch the facts onto a story, they're more likely to remember for their exams. Second of all, it breaks down the divide between facts and human beings. We also have a transition course. Empathy appears to decline mostly as they transition from the phase 1, the first few years, mostly lecture theater based, into the wild world. We also have a well-being stream. And of course, we teach communication skills, empathic communication skills. It's now being adopted in other UK medical schools. I had a call an hour and a half ago with a new medical school in the UK. They're going to adopt it, and this is growing. We hope to create, whereas the empathic hidden curriculum tended to drain empathy, this new curriculum is a hidden curriculum which makes empathy go up. We also deliver training to healthcare professionals in the UK, in Canada. I was in New York last week. And the evaluation is important to us. Everything we do is evidence-based, and the satisfaction is high. It's average over 9 out of 10. The students believe it will lead to them becoming more empathic practitioners. We are going to measure in the future whether that in fact is the case. The problem is the system sometimes. No matter how good our training is, if the healthcare practitioners go back into a system which drains empathy, if the leadership lacks compassion, their shift patterns are weird and they can't plan their wedding. There's no place to park. This food's pretty good, by the way, but if the food is bad, all those things which are at a system level, if the system drains empathy, no matter what we do, it won't have its desired effect. The good news is that you can change the system, and we have a system for changing the system, and that was developed here in this building with the late and great Ron Gottesman, who was a fantastic, very sad to learn of his passing a few years ago. We have developed a training to look at what can and cannot be changed within the system, then focus our efforts on things that can be changed and measuring it. We've also done it in the UK twice, but what's really cool is that we developed a measure of system level empathy. We took every single hospital in the UK and gave them a number from 1 to 10 on how empathic they were. And we didn't make it up. We took publicly available data from the NHS staff survey to find out, for example, do they rate their leadership as being compassionate? There's something called the space. There's data about the space. Is the space adequate? There's data about the well-being of the staff. We took those numbers all from publicly available data and crunched them into one number, 1 to 10. Every single hospital got a number 1 to 10. And then we tested whether those numbers were associated with better staff outcomes, better patient outcomes, and better financial outcomes. And it was strongly correlated. The more empathic the hospital, the better patient outcomes, better staff outcomes, in other words, better well-being. And the difference in financial outcomes wasn't that big. It was the same for some things, but they saved money, less money on consulting and less money on locum staff. What's the word for locum staff? Like same, okay, locum staff. And that was published in The Guardian about a month ago. We've also had recognition from the Parliament. We've been involved with the Department of Health and Social Care. As I mentioned, I was quoted by Baroness Amos. We publish everything we do. We believe that it's important, it's an ethical duty for us to publish what we do, so others can either, see it and unlike it or realize what they don't want to do. But we publish everything we do. We evaluate everything, and we're also starting to raise money from the major funding bodies like the NIHR, which is the equivalent of the CIHR here in Canada. So, coming to a close, I've spoken about the crisis, poor satisfaction, lack of harm is caused by bad communication, burnout. There's evidence that empathy can improve things, and we can and are putting it into practice. If we get this right, it won't be humans versus machines. It'll be humans and machines. Humans doing what they do best, giving great compassionate care, and the machines taking away the paperwork. I began by mentioning the famous Sir William Osler. I'll finish with a quote he said, "The good physician treats the disease. The great physician treats the patient who has the disease." And I want to thank people. Thanks to the wonderful Jeff Shammy. Thanks, Justin. Thanks to the Cedars Foundation, Michelle. Thank you very much, Michelle. And thank you to my family. My dad's here. My sisters are here. 2 of them are here. One of them came late, but she's right there. And my wife, maybe she had to run out because Otis, she's there. Where's Otis? Sleeping? Oh, no. Hi, Otis. So thank you, everyone. Thank you very much. Look forward to your questions.
Thank you, Professor Howick. That was a wonderful talk. And now, before we go to our Q&A, vous pouvez poser des questions en français. We'll do French and English. This is a bilingual hospital, but I'd like to ask our chair emeritus, Dr. Roger Taba, to come up and say a few words.
Jeremy, it's hard to believe you're Andy Howick's son, but your inspirational talk. And I'm thinking throughout this, yes, empathy can be taught. The problem is that we have this old model of medical school based on the old German model. You get 4 years and you have to cram in so many facts. My personal feeling is that the medical curriculum should be expanded to 6 years. I think, and that would allow us more time to teach empathy, etc. One of the things we have in Quebec in terms of medical training that I've always found fault in is that if you're an exceptionally bright student in high school and CEGEP, you can get admission to medical school when you're 20. Which is ridiculous. You come out as a practitioner at age 24, and even in my time, there were about 15-20% of the class was these early CEGEP graduates. And I always thought there was a difference between them and us. Those of us who had an undergraduate degree or a master's degree or had some other life experience, because these people were focused on getting through medical school. They were bookworms. They had no life experience. And I've often found that that was a criticism in the current system we have in Quebec. But my major complaint is that we have so much to offer in medicine. It's such a broad field, and we're still using the 4-year time frame that we used 150 years ago, the same model of teaching. It is really important to introduce empathy into the curriculum. And I'm glad to see that at least in the UK, your map with all the dots on it was phenomenal. Virtually every medical school is offering your program. But a significant number, looks like, is McGill offering this? Have they approached you?
Sure,
Yeah.
come up and answer,
Come on and answer.
and then we'll go into the Q&A.
So Justin knows more about what McGill offers than I do, so he'll correct me or add. But McGill has a fantastic professionalism course. They don't like the word empathy, and that's fine with me. They call it other things, but what they're doing is, I think, advanced compared to what most medical schools are doing. It seems great here. There's a lot of people. They let me use the office on at the Lady Meredith House, so I've met a lot of them. What they're doing, at least in the professionalism, looks really great. They've not evaluated it though, but that takes resource and expertise. They'd like to. In terms of in the UK, medicine is an undergraduate degree. Almost all of them come in younger than 20. And you're right. They struggle, actually. A lot of them struggle. And mental health problems. They need a lot of support. They need and have a lot of support. The trend, though, I see your point in extending medical school to 6 years. The trend is the opposite. I gave it a session last year at NYU. They did it in 3 years. In the UK, the government wants to compress it as well into 3 years. I'm not saying it's a good thing. I'm saying that you'll be fighting probably a losing battle if you want to get it to 6 years. Then the question is, how do you insert empathy training into a busy thing? 150 years ago, there's comparatively little to learn. They know so much more. How do you get all these facts in? I don't know how you do that. What I do know is that empathy doesn't take more time. So if you're delivering empathic care, we wrote a paper called 10 Things You Can Do to Enhance Empathy That Don't Take More Time. One of them is introduce yourself by name. I took my son, not that another one, to the urgent care center. We're waiting for a long time in a dirty room. All of a sudden, someone calls me. They had a dirty outfit on. didn't introduce themselves. I wasn't sure if it was I'm not hierarchical. I don't care if it was the nurse or the consultant, but I didn't know. And not knowing took my confidence away, made me have more questions. So just introduce yourself by name and say what you're doing. That doesn't take more time, even as you're walking. The coolest, another case is, no, I won't tell that one. That sounds bad. But another case is in this study in Texas, where surgeons would either stand up at the bedside and spend exactly 90 seconds, or they would sit down, and it was timed because it was part of a trial, and spend exactly 90 seconds. Afterwards, they asked the patient, how long did your surgeon spend with you? When the surgeon stood up, the patient said it was about a minute, not more than a minute. When they sat down, it was 2 or 3 minutes. So time is subjectively experienced. So the perception of time depends on body language. Then body language, no more time. So it doesn't take more time. In medical school, I don't know. I'd love to hear what Justin thinks. I suspect you can't learn the facts anyway. Even if you learn all the facts in 6 years, they change, the evidence changes. So it's an impossible goal to achieve. But the communication is really important. So there are ways to do it within the existing time frame. An example I gave before is getting real patients into the lecture theater during teaching of pathophysiology. Have I answered some of your questions? I'd love questions.
Yeah, let's just stay up here. We're gonna go to the questions in the house, and then we'll look to see if any chat questions online. We'll give everybody an opportunity.
Yeah, the questions.
I'll repeat the questions from the house so those on Hollywood Squares can hear us. Yep.
For health science education, so I'm very interested in the education part. And like most of us in this room, I have experience of being a patient. And I'm wondering how you talked about involving the patients in terms of coming into lectures, but do you involve patients who are in the hospitals when they're still seeing students and residents? We get them all the time if they're there. Involving patients to give feedback sort of in real time. You talked about studies where you're measuring, but I'm wondering, could you somehow be more intentional about involving patients in that education process?
Shall I repeat it?
You can do it, sure.
The question is about the extent to which we involve patients. We involve patients at every stage. So we have a standing patient advisory board that informs everything we do. So whenever we have a new idea based on evidence for any intervention in the medical school or in the continuing professional development field, we develop a draft plan and then invite a sample of patients, educators, and potential people who are going to be students or others to look at the plan and provide feedback to us. We also have real patient simulators rate the empathy of students in their OSCEs. So it's integrated in everything we do. If you're planning a conference, patients tell us they sit there, they get the right to ask the first question, they inform the plan. So involving patients is one of our core principles that we do at every level. We don't, though, I know we don't have patients on the hospitals walk around looking at the
For patients who are experiencing interaction. You talked about it as part of a study.
No, not as part of the study. No. And so let's say we want to. So the first thing I did when I arrived at the center 4 years ago is I gathered the patient advisory board. I said, here's our plans, not just studies, and for everything we're doing, whether it's a study, whether it's a one-day teaching course, whether it's a conference, the patients provide their views. Does that make sense?
Yeah.
So it's not just a study. The studies were actually in the UK were required. So now I'm applying for a major program grant. We have 2 patient co-applicants, and that's 20%. So there's almost nothing that the center does that I do without patient input. We don't commit ourselves to agreeing with everything they say, and they actually appreciate it, because once some people just listen to them and they say yes to everything and they don't do it. It happened actually about 6 months ago where I forgot to involve them in the design of a conference. The conference was for teachers, and everyone was giving me advice. Oh no, just don't hide it. Don't tell them about it. I said, you know what? Stuff it. I made a mistake. I emailed them all, the board. I said, I effed up. apologize. It hasn't happened before, won't happen again. Here's my proposal. They said, thank you so much for being honest to us and giving your view. So yeah, we have a great relationship with our patient advisory board, and they're involved at every stage. And something we're quite proud of. Yeah. Well, we can always learn more. If you have any ideas, please send them.
Thank you for that question. Next question. Okay. George, one of our volunteers.
Hi, George.
Hi, thank you. I was wondering, you consider empathy an emotion?
You're asking if I consider it an emotion.
Yes, and in that case, can AI have emotion?
Aha. So your first question is empathy an emotion? In the literature, they divide empathy into cognitive and affective. So thinking and feeling both. I think that divide is artificial. You can't possibly watch someone trying to cross the Grand Canyon on a tightrope without feeling a bit of vertigo. So I think that understanding something and feeling, to me, they're tightly knit together. Can AI feel it? No one knows. It comes down to the Turing test. Alan Turing was asked about do computers have intelligence? It's impossible to answer. You can argue for thousands of years and you'll never get a definitive answer. So what Alan Turing did for computers is he said, forget asking whether they're intelligent, just ask whether they can do things that intelligent people do. And on that basis, they can do. With empathy, ever since the 60s, Joseph Weizenbaum at MIT developed a computer program called ELIZA. Very simple program, imagined in the 60s, that mimicked Rogerian psychoanalysis, which is one of the kind of forerunners, the roots of therapeutic empathy. And on the screen, people would type in things like, I'm having a bad dream. Said, oh, what about your father or something, whatever it is. And then they couldn't tell the difference between a real psychotherapist and ELIZA, this very simple program. So nowadays, it's the same thing. People cannot tell if something has emotion or not, but whether it actually has emotion, I don't think it does, but I couldn't prove it to you. Does that answer your question, George?
Yeah.
Thank you.
Michelle, anybody else? Anybody online, Michelle? Oh, sorry. Two more here. Go.
My name is Bryn. I'm a psychology intern. I was just curious about when you talked about empathy, sometimes causing burnout, sometimes not causing burnout. What's the difference?
So when I first,
Maybe repeat the question.
oh, sorry, the question is, I cited evidence that there's a negative correlation between empathy and burnout. More empathy is less burnout. And you want to speak more about that. So anecdotally, people do report that more empathy, more compassion is more burnout. I think what that is let's say you're a psychologist working in an intense psychologist working in a building. If you're the most empathic, compassionate one, your colleagues, usually it's going to be a female, but not always, going to give you the tough patients. You're the good one. You're good at it. They give you the tough ones. But it's the dealing with a tougher case, though, that causes the burnout. That's my hypothesis. The second thing is I provided the reason why being a healthcare practitioner is a wonderful profession. It's why it's so widely respected. You're helping people. Everyone knows from their personal experience, if you're feeling a bit down, the easiest way to feel a bit better is to do something nice for someone. Buy a cup of coffee for a homeless person, you feel better right away. That's what healthcare professionals do all day. So when they're in, the empathy puts them in touch with that and allows them to experience less burnout. What I will say is that the definitions of compassion in the literature, many of them advocate mirroring the same emotion as the patient, the same feeling. With empathy, it's not the case. Feeling's okay, but not the same thing. If one of my colleagues is a GP for homeless people, they often come in there angry, demanding drugs he can't prescribe them. He can't do it. So, but if he were to mimic the same emotion, it would be bad. Or if someone feels attracted, so that's not, you don't want to mimic that. So feeling is okay, but professional boundaries are important too. And emotional regulation is important. That's what protects you against the burnout. So feeling is okay, not the same thing. And professional boundaries and being in touch with the fact that you're helping is what protects against burnout. Does that make sense? Thank you.
Thank you for that question. We have behind you. Yeah. Hi.
Hi, just a quick question. So the data seems really clear between patients improving and empathy. So my question is, why is that? Is there an obstacle that you face in implementing empathy as a program into healthcare? Is it related to why people actually go into healthcare in the first place? Because the first thing you would think is that they would want people to get better. So if it's so clear that empathy helps, is there an obstacle that you face and why?
I thought this is my sister. I thought she was going to heckle me, so I'm great. So yeah, is there an obstacle to implementing empathy? So first of all, medical school curricula are jam-packed, and I'm not the only game in town. Everyone, the person who teaches the cardiovascular system, they want more time. It's you know, as you know, Roger mentioned, it's a jam-packed curriculum. So even if it is a great idea, and I can show it's evidence-based, which it is, it's tough to get anything squeezed in. Ditto for training in hospitals and so on. They're busy. That's why I'm very grateful. I haven't said it, but thank you for making time to come here. So that it's a packed, they're busy people. The second thing is, you mentioned why people go into the medical profession. People often tell me, oh, they go into become a doctor because they're naturally more empathic than everyone else. The fact is, it's not true. There's a variety of motivations for want to become a doctor, and that's fine. But it can be parental pressure. It can be because, you know, they want to get a great job. It can be for money, and like anything else. So they're not. It's important not to view them as more than human, which is why it's been tough. It's really tough getting this stuff in. At Leicester, we're lucky because we had a philanthropist who basically gave money to the university on the condition that they be nice to us, and otherwise they'll revoke the money. So. But that just applies to my university. Doesn't apply to, I was at New York University last week, doesn't apply there. So there, you've got to show that it is evidence-based and it saves money. That makes them wake up. And then the burnout thing is important too, because medical student burnout is a huge problem. Even if, what does McGill have, 150 students a year? If they lose even 1 or 2 a year, it's a big deal as far as their bottom line is concerned. So if you can reduce that impact, it's important. So I have to learn the arguments that they hear. But thanks for that question. Thanks for not heckling me.
Thank you.
Quick question.
Sure.
We've actually got 22 people online who joined us. I have a question here from Cleopatra, which don't believe empathy belongs in every profession or occupation. Perhaps it could begin during early childhood education.
Good question.
Yes. Should empathy not be involved in all professions? I get that. I had the Bishop of Leicestershire invited me to his house or something a month ago, saying that the Department of Work and Pensions needs empathy training. Other people call me and say that the police force need it. That's all probably true. I try to teach my kids empathy, although my wife probably says I don't do it as well as she does. Yeah, I only have a certain amount of time, but it definitely would be important. And the same principles apply, and we have actually tested it in some adjacent professions. So at the University of Leicester, one of the departments wasn't doing very well. And the reason was the lecturers, the professors, the teachers were not being empathic towards the students. So we introduced empathy training and it's improved things.
That's great.
So it should be, but I can't do everything. And insofar as it is, it's looking good. Thank you.
Dr. Howick, stay here with us for a minute, Professor. So I just want to shout out because it's 1 o'clock and some of the healthcare professionals have to go back and they've come to the Cedars CanSupport Lunch and Learn. And for those in Hollywood Squares, we're very grateful. We had like over 28 people I saw at one point and a full house. So to bring our volunteers, our Cedars CanSupport volunteers, who Jeremy every day in and out, they're with our patients as they navigate through their cancer treatment here at the Cedars Cancer Center, to our doctors, our psychologists, our PSO team, to our allied health workers, social workers, those caring for our patients in every part of the hospital and part of the Cedars. We say thank you for coming today. Thank you for reaching out and listening. And I just want to shout out to the Cedars CanSupport team, to Virginia and Anna, the 2 co-directors, and their team of Bronwyn, Lauren, Malcolm, and Thomas, the intern. Thank you. And to the Cedars team, I wanted to shout out to Ariel, Michelle and her team, Evie, and Angus. And thank you for putting this on. Jeremy, it's your second time here. Gwen wasn't here when I introduced Jeremy. He was our inaugural Tom and Gwen Naquist visiting professor in 2023 when we got that lovely gift, Gwen, from your family to in perpetuity to bring a world-class palliative and supportive care practitioner annually to the MUHC. So that was 2023, and we're happy to have you with your family here today. And if I can just, Gwen and to Jim Hindley, 2 past chairs of Cedars are in the house. I don't think I missed anybody else. Thank you, everybody. Please, we do not have to leave, but I know those working have to go back, so we'll let you off the hook. And thank you for this wonderful talk.
Thank you, everyone.
Thank you. Thank you.